Okay, good morning everybody, and welcome to the Patient-Centered Primary Care Institute webinar, Care Plans, Best Practices for Development and Implementation. Before I turn things over to Evan to get started with our presentation, I want to review a couple of things about the technology that we are going to use today. So we have about, I think, 65 of you on the line right now and more joining, and probably will join in the next couple of minutes. So everyone is on mute and will remain on mute throughout the presentation. We do, however, have plenty of time set aside to take questions. So when we start Q&A, there are two ways that you can ask a question. You can use the little hand icon on your GoToWebinar control panel. When you click that, it raises your hand and lets me know that you have a question. I can unmute your audio line and allow you to ask your question. But to do that, you need to enter the audio pin that is on your GoToWebinar control panel. You can go ahead and enter that now. If I see that you have your hand raised and you have a question but you haven't entered that pin, I'll go ahead and send you a quick notification with the pin, and you can enter it at any time. If that technology is, difficult for you, or for whatever reason you can't be unmuted, you can type your question into the question pane, and I will read it for you and have our presenters answer it that way. We will be sending all webinar participants a link to the recorded webinar and the slides after the presentation today, so I can save you that one question, and you'll be able to access that information through our website as well. I'm going to go ahead and hand things over to Evan to get us started with the webinar this morning.
All right, thanks. Thanks a lot to everybody for coming on this important webinar at an early time in the morning. I'm just going to first of all go over the agenda for the webinar. We're just going to do a little overview of the Patient-Centered Primary Care Institute to start, give you a sense of what the Institute is about. We'll talk a little bit about care plans generally. What are they? Why do we use them? Why are they important? And then we're going to have two folks jump on and tell us how they've actually started to implement care plans in their practices, both a pediatric setting and internal medicine setting, which hopefully will offer you all real-world experience that you can learn from. And we'll have question and answer sessions or time between those presentations as well, and then we'll finish up. So again, my name is Evan Salino. I'm a clinical advisor for the Oregon Health Authority, the Patient-Centered Primary Care Home Program. I'm working, as part of my work, I work with the Patient-Centered Primary Care Institute, which was launched just last year as a public-private partnership to advance patient-centered primary care home practice transformation across the state. It's a partnership between the Health Authority, the Northwest Health Foundation, and Quality Corp. And really the idea is to sort of form a one-stop shop, a place where there's a broad array of technical assistance for all practices at different stages of transformation, and really provide an ongoing mechanism to support practice transformation and quality improvement in primary care setting across Oregon. We have just started to set up a learning collaborative of 25 practices throughout the state, where we'll be learning from each other with specific technical assistance resources provided to those practices. There will be online resources available to the whole spectrum of folks across the state and beyond. The website, which was just recently launched, is there on the screen, PCPCI.org, and I encourage you to go there and check things out, especially with the growing resources that we'll be adding to that. We'll be doing webinars like this one on a whole variety of topics, some foundational topics around patient-centered primary care home, some advanced topics as well. And we'll be developing right now online learning modules for you all. And really to keep track of what's going on, the new things that are coming out, if you go to the website and sign up for the newsletter, you'll start getting notifications when new things are being added to the website and webinars are being scheduled, et cetera. So just to start with the patient-centered primary care home model that Oregon has defined as sort of the standard of quality primary care across the state. It's defined by these 6 core attributes, which are there on the screen: access to care, accountability, comprehensive whole person care, continuity, coordination and integration, and person and family-centered care. This provides practices a framework to really understand how to improve the care that they give. Each of these core attributes have standards and measures that you can meet. And really, what we're talking about today, care planning, really touches on a variety of these different core attributes, including accountability, that comprehensive whole person care, that coordination and integration, and the patient and family-centered care. So it really is part of really all of these, a number of these core attributes of the patient-centered primary care home model. This slide here shows you the current standard, the current patient-centered primary care home standard, core attribute 5. There it is there on comprehensive care planning, that discusses what care planning is, what it can be beneficial for and used for folks in high-risk medical environments and patients with special health care needs. This gives you the current situation. And this slide shows you the new standard that will take effect July of 2013. These new standards were developed by a standards advisory committee with a broad array of stakeholders, and those are out for public comment for the next 6 months, but then will be implemented in July of 2013. And this just shows you essentially a very similar standard that will continue to be in place when the new set of patient-centered primary care home standards are implemented in the summertime. So the idea of care planning is really means different things oftentimes to different people. Some people think about it as end-of-life planning. Some people think about it as disease-specific planning. Some people think about it as a way to keep people out of the emergency room or things like that. And really, ideally, it is, or it could be, all of those things. And really, how it's used and what it's used for is up to you. Hopefully, if you look at the literature, you see, especially with the pediatric population, which really, those are the folks that really established a lot of the foundational aspects of the patient-centered primary care home model. In the pediatric population, you see really successfully used care plans, specifically disease-specific care plans, for example, for asthma action plans, things like that, but also for other issues where that coordination or understanding what care should be for a complex patient is very important. For example, in congenital or developmental conditions, can be very helpful in mental health conditions such as ADHD. And again, in adults, mental health conditions is a prime example of where care plans are currently used, as well as disease-specific things such as diabetes, palliative care, COPD, where really the evidence shows significant benefits when care plans are used so that patients understand the sort of care that they are going to get, and providers also understand the type of care that different providers are giving, and also the type of care that the patient wants. And that really leads to that next point, which is that evidence definitely suggests that patient engagement and their goal setting is important to their empowerment and the outcomes of the care plan. So if the care plan is to be effective, evidence suggests that the patient setting the goals is really one of the most critical pieces. So we have our own goals of a pediatric patient using their controller inhaler twice a day like they're supposed to, or a diabetic with a hemoglobin A1C under 7, but those aren't usually their goals. So meeting patients where they are and helping them establish their goals in a context of their illnesses if they have them, that's really what is going to make a care plan successful. The other key is really to engage a multidisciplinary frontline staff in planning and using this care plan. So everybody can create the most amazing care plan and sit down for an hour with the patient and fill it out and do this amazing thing, but stick it somewhere where it's never used again. Or if staff is engaged in developing the plan and how it's going to be implemented and how it can be used, this could be a living document that changes over time, that really reflects the patient's situational time, reflects the types of care that they're getting in different locations, and really facilitates care and facilitates being able to touch on goals that the patient sets and move back to the sort of the medical side of where that fits in the overall context. So one of the main reasons we're having this care planning webinar today is because of the requirements for the Medicaid patient-centered primary care home payments that many clinics are seeking to try and make this financially sustainable. So the Affordable Care Act set out certain diagnoses and certain sets of more complicated patients to receive additional payments. The clinics would receive additional payments for those patients. But part of that is, the requirements behind that is that clinics have to establish a care plan for these patients within 6 months of the patient essentially being identified with the clinic, or the clinic being paid for that patient. Again, there's reasons behind that. This is not just a checkbox thing, but there's really good evidence that for more complicated patients, care plans make a difference. So it's important to understand that the care plans, and this is straight from the Medicaid payment program rules, that the care plans must include self-management goals, preventive and chronic illness care goals, action plans for exacerbations of chronic illness, and, if appropriate, end-of-life plans. So that's laid out in the rules, and I just present that as a way for you all to organize and think about what it means to have a person-centered care plan as opposed to a disease-specific care plan, you know, what Medicaid and CMS have required for these payments. And with that, I think what I'd like to do is hand it over to R.J. Gillespie and David Ross, who are pediatric colleagues, who are going to tell us about how they've developed the pediatric care plan. I'm going to switch over to them. Let's see. Here. And, all right. And David's got it, so we'll let him take it from here.
Okay, good morning. This is R.J. Gillespie. As Evan said, I'm a general pediatrician, and I'm the medical director of the Oregon Pediatric Improvement Partnership. We have been working in collaboration with the Oregon Rural Practice-Based Research Network on a learning collaborative with 8 practices across the state working on medical home principles. We have kept a focus on medical home broadly. We have had all of our practices implement the PCPCH standards, but have also looked at other definitions and kept a broader look at medical home. And so far, 3 of our 5 learning sessions have been completed. So we've worked with our practices on identification of children and youth with special health care needs, on care coordination, of which shared care plans is a component, and also on behavioral health integration. And what we're going to do today, I'm going to talk a little bit about the context of what we taught our practices that shared care plans should be, and then David Ross is going to talk about what the practices have actually done and how they've made this go live in their practices. So as background, this is a quote from the Medical Home Info website. So this is the National Center for Medical Home Implementation, which is a pediatric-specific resource. Every patient can benefit from a care plan or medical summary that includes all pertinent current and historic medical and social aspects of a child and family's needs. It also includes key interventions, each partner in care, and contact information. A provider and family may decide together to also create an action plan which lists imminent next health care steps while detailing who is responsible for each referral, test, evaluation, or other follow-up. I think as pediatricians, we've looked for a long time at action plans and have done quite a bit of work specifically with asthma action plans as an example. But there's some key differences between action plans and shared care plans, as Evan mentioned. Some of the key differences that we see, first of all, action plans are usually completed by a provider, but shared care plans are meant to be co-written. So they're collaboratively done between the provider and the patient or family. Action plans generally will have directions for what parents or patients are supposed to do with exacerbations of their illness, but shared care plans are going to have patient-centered elements. And most importantly, this includes patient goals and the steps that patients or families would need to take to get to those goals, and also includes an understanding of the barriers that are being experienced by the patient and family. And in the end, shared care plans are meant to emphasize the patient's own role in managing their own health. So for children and youth with special health care needs, these shared care plans are not meant to be directive, but are meant to be empowering. So oftentimes for a patient, understanding a disease process and provider instructions for how to manage that disease can be fairly overwhelming. So when patients are quote-unquote non-compliant, generally speaking, they don't understand or can't follow through on directions. It's not that they're willfully ignoring the directions of the provider, but they're not capable for some reason. So shared care plans are meant to help pull out the patient or family's priorities, their strengths, and their beliefs, and ideally will help the patient to advocate for themselves and to educate and empower themselves. In terms of different types of care plans, medical summaries and transition summaries are usually meant as communication tools between settings of care. Emergency care plans are usually meant for the families to understand what they do with exacerbations of illness. And then the working care plan or the shared care plan, again, is meant to be a little more comprehensive and to help break down steps that patients or families can take to manage their own illnesses. And then in pediatrics, we also consider individual health care plans for educational settings as another type of care plan that is important to consider. Ideally, shared care plans, again, will contain a number of elements. So they're listed here. I'm not going to go through them in detail. Ideally, these should also include resources for where a patient can learn more about their own disease process. So as Evan said, shared care plans are meant to be living documents, so they are going to change as the disease either improves or worsens or changes in some ways, as goals are achieved and as the patient becomes more empowered in their own self-management. So shared care plans are meant to be revisited, either over phone consultations or in follow-up visits with the patient, but should be updated on a regular basis. It should go without saying that shared care plans should be patient-centered, and so in an ideal setting, these would include statements that describe the patient in their own words. So things I want the person working with me to know. The most important information you need to know about me is I have a challenge with my religion or spirituality does or does not impact my health care, how patients learn best, and what the patient's concerns are and where the patient wants to end up. As I mentioned, asthma action plans are a fairly concrete example that most pediatric providers have used in the past. And these obviously include elements such as what a patient should do if they have an exacerbation of their illness, but also what they do when things are going well. It includes a list of their medications, their emergency contacts, and then consents and signatures. Obviously, action plans have an important role, but how easy would it be to make an action plan into a shared care plan? So the simple things that you would be adding into an action plan to make it a shared care plan would be assessing the patient goals and potential barriers to treatment, figuring out ways to help the patient problem solve these barriers, and then documenting these goals and barriers on the plan itself. So important steps in the development of a shared care plan is the concept of self-management support, which emphasizes the patient's central role in managing their own illness. This is the Institute of Medicine's definition of self-management support, the systematic provision of education and supportive interventions by healthcare staff to increase patients' skills and confidence in managing their health problems, including regular assessment of progress and problems, goal setting, and problem-solving support. There, in the literature is listed out 5 A's of self-management support. The first is to assess the patient's belief, behavior, knowledge, and readiness to change. Second, to advise the patient by providing specific information about health risks and benefits of change. So this is the provider's primary role in educating patients about their disease and the risks of not managing disease. Third is to agree on collaboratively set goals based on the patient's confidence in their ability to change the behavior. And the last two, which are less frequently done in clinical settings generally, are first assisting the patients in problem solving by identifying personal barrier strategies and support, and then arranging a specific follow-up plan. In general, with goal setting for shared care plans, again, we want to work collaboratively with the child or family. You try to identify goals that are specific and short-term. So something that can be easily achieved, and we think in general that you want to look for small, short-term goals that help to build the patient's confidence that you can build on those successes in the future. So again, start small and then build on those successes. It's important to provide regular feedback, so either by phone follow-ups, by email, or face-to-face visits to assess how the patient is doing with their goals and if they're experiencing new barriers that they hadn't identified at the time that they set the goals. And And obviously, we think that the goal setting and the evaluation of those goals is a team approach. So it doesn't have to be all provider, but other allied office staff can help to assess the goals and how those are going. So as quality improvement experts, we use the Plan, Do, Study, Act cycle, even with our patients, in terms of helping them to understand how to get through their disease and how to get through their specific goals. So I'm going to, at this point, turn it over to David, who is going to talk about some examples that we gave the practices and how the practices have actually implemented those in their offices.
Thanks, RJ. So first I'll say that we've put together a PDF portfolio of various examples that we have available. So if you'd like a copy of that, you can contact us, and this information is at the end of our slide deck, but at opip@ohsu.edu. And we can send you that. Also, apparently there'll be a checkbox in the survey at the end of this webinar if you're interested in getting that information. And that has many more examples. And given our short time here, we didn't include a lot, but wanted to put that together for you and make that available. In addition to giving some examples here, we just want to emphasize that this is a process in a practice. Anytime you make a big change in clinic flow or a practice within your clinic, you should do it intentionally and strategically and use methods that get you to the change you want and an improvement. So we'll talk a little bit about that. What you see on your screen here is an example of an action plan, and this isn't a complete shared care plan, but elements of this type of document elements of an action plan are important in a shared care plan. So this kind of scale of how important they think their goal is, and some of these things are valuable and things you might consider including in a shared care plan. This next example is a child health coordination plan. It shows different concerns and issues and how you can track referrals and who's responsible and keep accountability by including date and action items. An example of a shared care plan in one of the practices we work with, Woodburn Pediatrics here. This is an example of their shared care plan. And given time, I won't walk through the specifics, but that's in your slides. It includes goals and to do and who's responsible and various aspects of the child's health information. Some important considerations as you implement shared care plans that we've documented as we work with practices that have done this and have started this. One is that, in general, the process will differ in each practice. But one thing that's really, really important is that you involve diverse members of the team and that you include families in the design of your shared care plan. So if one person in your practice just designs it and then you try and implement it, that's probably not going to be a valuable way to start the process and to get the process moving. So it should be collaborative. It should involve a team of diverse members in your practice, and including families has really come out as an important aspect of the work. Remember to test changes with small pilots. It's easier to do that and make small discoveries than get far down the road with a shared care plan and implement a bunch of steps and get to a point where you realize it's not going to work and it's not doing what you wanted it to do and it's not effective. So small discoveries instead of big mistakes. Use the PDSA cycle. Work on small tests of change. Review by external entities and parents has been and will be valuable. So practices we've worked with have sent their care plans to us, and we've looked over them, and our partners have looked over them. We've sent them to parent partners that we work with to review them, and that's been a valuable activity. Practices have used their EMR technologies in various ways. I can't think of one that started by trying to integrate. So a good first step is drafting a template first on paper before considering integration, but every practice has moved that direction since starting there. This example is from the Children's Clinic of how they've integrated some of their EMR and their shared care plans in integrating the use of drop-down lists for goal setting and documenting successes.
I think the other consideration, just to jump in for a quick second in terms of implementation, is one of the things that we found in pediatrics that is, I think, a critical difference perhaps from internal medicine is that we try to encourage practices as best we can to think about non-condition specific action plans in terms of the templates that they build. In pediatrics, what we have are a large number of low-frequency conditions that we're generally creating action plans for, and so we don't tend to do a lot of condition-specific ones. We obviously have one for asthma, one for ADHD, but in general, pediatricians need to think also about a non-condition specific action plan. So the example that was given from Woodburn was meant to be used for any potential condition, so it's not meant to be a disease-specific shared care plan. I think, again, in internal medicine, oftentimes you'll have a shared care plan for diabetes or a shared care plan for congestive heart failure, or things like that, and that would hit the bulk of your special health care needs patients. But in pediatrics, we tend to emphasize more of a non-condition specific general boilerplate shared care plan for use by the practices.
Great, thanks, RJ. And one other thing that I want to note as we're getting close to our time is that with the payment, enhanced payment that can be associated with the ACA kids, it's tempting to kind of take a bigger bite than you can chew as far as creating shared care plans for all kids that might be eligible. And one piece of advice we definitely want to put out there is that the practices that have taken smaller chunks and started with a smaller group and then expanded and built off of that have been more successful. So that's one thing we want to put out there also. Soliciting patient feedback and family feedback has been, again, as I said, a big deal. We have had numerous practices do that, and it has been a valuable experience for all of them. What is on the current slide and is your slide deck is an example of what you might do as you implement shared care plans to get that feedback and a way to do a small test of change in that way. This slide just has some bigger ideas about getting patients involved, incorporating patient feedback and suggestion process in general in your clinic. Hold brainstorming sessions with patients and families before developing shared care plans and involve them throughout the development process. Appointing patients and families to task forces and work groups to review shared care plans under development. And evaluate yourself from the patient perspective. So conduct patient surveys of your own and include questions for children use of special health care needs about the shared care plans. So I'll pass to RJ to...
So just to conclude, again, shared care plans are different from action plans in that they are meant to involve patient goals, barriers, and the steps that patients need to achieve goals. We think it's important to involve patients, families, and youth in the development and implementation of the practice's shared care plan. So not only helping to develop an individual shared care plan for a patient or family, but also to look at the broader templates and boilerplate shared care plans that you're using and get your patients' feedback about whether the structure is helpful, whether the format is helpful. And as Dave said, small tests of change leading to big improvements. I think it's important to take off a bite of special health care needs children that you can reasonably manage, test how the shared care plans are going with that population before expanding it onto the broader population. And when you look statistically at kids with special health care needs, that, depending on how you define it, could be as much as 30% of your pediatric population. So starting with a small group, seeing how it works out, and refining the process before you spread it on to the larger population is probably going to be a helpful thing. So as Dave mentioned, if you have any questions from us or want more information, we have a few minutes to take questions now, but you can also email us or visit our website to get more information. Thank you.
Okay, thanks so much to both of you. So we do have a couple of minutes to take a few questions. So for those of you, if you'd want to ask your question over the phone line today, feel free to use the little hand feature to indicate that you have a question, and I can use that to unmute your line and provide your question to the presenters. We do already have one question provided via the chat box, and that question is, would these shared care plans be available for healthcare teams in the community setting to utilize and update, for example, home health and hospice?
I think that that's the next sort of step in terms of shared care plans is, you know, we've focused at this point on sharing the care plan between the primary care provider and the patient. But ideally, a shared care plan would integrate specialists, home visitation, and school systems and other groups who have a stake in caring for a child and for ensuring their health. So I think that in an ideal setting, yes. The thing that I'll say about shared care plans in general is that they're tough. So I think what I would probably start with is the simple patient and provider shared care plan, and then test how you're going to integrate those other elements in terms of specialists, home visitation, education, and other healthcare providers.
Okay, great. We got another great question. Does the provider have to be the one to put together the care plan with the patient, or can it be done by a nurse care coordinator?
Absolutely not. It does not have to be the provider. It can be a care coordinator. It can be a nurse or an MA. It can be. It's going to depend on your practice structure. All of our practices have care coordinators at this point. They didn't start with them at the beginning of this learning collaborative, but they do now. And this is one of the primary functions of the care coordinators within the clinics, is to work on these shared care plans. That said, it's not always going to be reasonable for every practice to have a care coordinator, so it can be whoever in the practice has that skill set. So sometimes it's going to be the provider, sometimes a nurse or an MA, and sometimes a care coordinator, depending on what your structure is like.
I think also what we're finding with our practices is because they're a lot harder to do and because they're trying not to create a workflow problem, that they're using care coordinators to do some of the work on the front end. So as part of their pre-visit planning, filling in the components that they can with the patients and kind of setting the context and the framing about what these documents are, so that some of the legwork can be done beforehand and then they can be reviewed with the provider when the parent comes in, and then that's a tool that the care coordinator uses when they follow up with them monthly.
And that, by the way, is Colleen Rulin, the Executive Director of OPIP, since she wasn't introduced earlier.
Okay, we're going to take a couple more questions and then move on to the second part of the presentation, but there are lots of good questions coming in, and if we don't get to your question out there, we will try and get to it. We have another Q&A built in at the end. But one question we have right now is we are finding that shared care plans and EHRs are in direct conflict, and it's hard to build the flexibility of an individualized care plan into an inflexible EHR. What thoughts do you have about that?
I totally agree, and I think that's one of the big challenges that the practices are having, and that's why a lot of the practices didn't start by putting it in their electronic health record. So most of the practices are starting out with some sort of paper version that they can work with and have it be a little bit more of a living document. What the Children's Clinic has done, at least with their ADHD patients, is as they loop back around to talk about the goals, they move those into a successes kind of bucket and then type in new goals into the drop-down boxes. But it means that every time you update the shared care plan, you're putting it out again and kind of giving the updates to the family. But I agree that that's one of the complications, is that it's very difficult to do this with an EMR system, and so many of the practices still are not. They're still doing it on paper and file folders, basically.
Yeah, big drop down. It's open text fields that you can't search. Or I think the biggest part that they've been having problems with within the EMR is the referral tracking components, given how difficult that is too.
All right, I think we have one more question that I think we're going to direct to Evan, because we've gotten a couple questions about meeting requirements for reimbursements. So I guess we'll go with, I thought for PCPCH, Oregon required care plans to be developed by a licensed staff person. Do you want to take that, Evan, really quickly?
Yeah, so that is a requirement that they be developed by a licensed staff, meaning a MD, RN, PA, et cetera. It doesn't mean that they have to be actually physically filled out by a doctor with the patient. The licensed staff, the primary care provider, ideally would be involved in the development of any care plan, would be reviewing any care plan at some point. That's really what we're looking for. Again, it doesn't mean that the doctor has to sit down physically with the patient and be the person to fill out the care plan. As RJ mentioned, that can be a variety of people in the clinic that can play that role. And then, and Colleen also mentioned, that prep work allows the primary care provider to review the care plan with the patient and understand what's in there and be involved and use that, again, as a living document, but they don't have to be the only person involved. Hopefully that clarifies.
Okay, we got a number of other great questions. Like I said, there'll be some Q&A at the end, and then if we happen to not get to your question at all today, you know that we will forward it to our presenters and have them follow up, and we will get back to you. So we're going to go ahead and move on now and hand things over to Jackie Ross at Legacy.
All right, Jackie, you've got the controls. So Jackie is a manager of Health Home. The Health Home program is through Legacy Health and has done a lot of work with clients there. So go ahead and take it, Jackie.
All right, thank you, Evan. I'm not seeing a way to move the slides. There we go. So I'm the manager of Health Home Support, so our medical home transformation here at Legacy Health, and we have we're a 6-hospital system with 19 primary care clinics that are a mix of internal medicine and family practice, and 13 of our sites in Oregon are Tier 3 patient-centered medical homes with the state of Oregon. So that's kind of what drove us to start looking at developing a person-centered care plan. So as we were starting to look at this, we realized that this really needed to be a system-wide collaboration. A number of our hospitals had already created their own ED action plans that they were developing for patients, and they were the nurse case managers within the ER were developing these for their highest utilizing patients, and then coordinating with the primary care provider and doing this kind of for not just Legacy patients, but for other patients who see providers at other clinics. At each hospital, and then us as the clinics, had our own ideas and our own version of what we were going to do. So since the clinics had a reason that we had to move forward with this, we decided to start meeting with each of the hospitals and actually developed a collaboration with our Director of Care Management from the inpatient side, and got representation from the clinics and from each hospital site to start developing one person-centered care plan that would be consistent for the patient throughout, whether they're inpatient or in the clinic. And we definitely wanted to make sure this was a person-centered focus rather than a provider-centered focus. As we started looking into what had already been created, we noticed a lot of things, especially in the ED, were directed at reminders for the staff of treat patient with respect, or don't send this patient on a bus, they need to be sent home via taxi or something. And so how do we make this more focused on the patient's need rather than a staff reminder? So what we developed into our person-centered care plan was a combination of primary care needs and the ED needs in order to get one plan for our patients. So within the primary care side, we have a medical summary and just a brief history of what's going on with the patient, that they're a diabetic or they have heart failure, and how long and what types of things have been going on with them clinically. And then we've set up where the patient's care team, as long as it's documented within our EMR, pulls into the care plan. So you can see if they have a psychologist they're working with, or an endocrinologist, any type of specialist, who their primary care provider is. All of that pulls right into the care plan. And then we've set the patient's care goals. And we have either a provider or a nurse can work with the patient to identify their goals. And the care goals are kind of a combination of what are the provider's goals to decrease their A1C or decrease their LDL. And then another section is purely the patient's self-management goals. So what does the patient want to do in order to follow through with what the provider wants, and what does the patient want? And then we've also put in a section to identify what are the patient's barriers to care. So what prevents them from going for a walk? Are they a fall risk? Do they live in a neighborhood that's insecure, that they don't want to walk outdoors by themselves? Do they have transportation issues? And then we've also developed as needed an action plan for behavior management. So especially focusing on any of our patients who are high utilizers, what do we do if they're coming to the ED instead of going to the primary care office first, or they're coming to the ED at 5:30 in the evening because they know they can get in right away? And so that's kind of an as-needed section by patient. And then once the care plan's been developed by either the nurse case manager or the primary care provider, it's able to be updated by anyone in the clinic. So if the medical assistant is discussing some things and doing some education with the patient, they can update the patient's goals as they're having those conversations with the patient. And the way we've set it up is there's a dot phrase within our system, and it shows who created the care plan, and then it shows the last person to update the care plan and when. At the bottom of our care plan is the ED section that covers the medical action plan for an exacerbation of chronic disease. So, you know, if the patient, what to do with this diabetic patient who comes in with an A1C of 14, or what to do with our patient who's seeking narcotics at the ED, not to give them narcotics or to refer them back to primary care, and then an ED staff treatment plan. So that section is where we have the reminders for what the ED staff needs to do for this particular patient. This section of the plan is initiated by the nurse case manager within the ED in collaboration with the primary care provider, or with input from a case conference committee if the patient doesn't have a PCP, because what we've discovered through this collaborative process is at some of our hospitals we have a high number of patients who are uninsured, don't have primary care established, and our nurse case managers were not comfortable with setting up the plan on their own. So we have a monthly case conference at each of the hospitals that acts as kind of a review board for anyone who doesn't have a primary care physician to provide input on this plan of care. And then the ED section is highlighted in red at the bottom of the care plan. And that was agreed upon to make it easier for our ED providers to find their section. So this is an example of a fake patient's care plan, but it's a smart phrase within our medical record system. And we agreed on the location of the documentation to go on our patient snapshot. So anyone who opens the chart for the patient sees this, and it was originally located for everyone at the top of the snapshot. So our primary care physicians found that a little challenging because it would then cover up all the information for their preventive health needs, their problem list, their medication list. So we're actually working with our IS department for the primary care division to move this to the bottom so that the first quarter of the care plan will show up, and then they can scroll down to read the rest. And then in the ED, it'll still show on the top. So we have it in the care coordination section of our snapshot. And the other piece of this is that that's a section we can't pull a report on it, but we are going to be able to turn on a print grouper so that this will come out on the patient's after visit summary. So when they're in having their visit with the provider and we set new goals or start their care plan, it'll print out when they go home and they have something to take home that's tangible and they know what they're working on. So some of our ongoing next steps are to continue meeting as a collaborative group with representation from the hospitals and the clinics to keep revising the person-centered care plan to make it the most efficient for all of our providers and for all of our patients. And we're working on developing an educational primer for all of our staff, so it'll be the same. With the clinics having a deadline of how soon we had to get these started, we went through and did screenshots of our EMR system and have done education to our nurse case managers initially to start the care plans with our highest utilizing patients, because those are the patients they're working with, those are the patients they're aware of, to get the care plans kind of going. But what we're working on is one primer that'll be the same for our clinics and for our hospital and nurse case managers so that they all have the same education on how to develop the tool along with the patient. And then we're looking at applying internally for a quality award with Legacy as a collaborative team with the hospitals and the clinics. And so at this point, I think we have some more time for questions.
Yes, thanks so much, Jackie. So I want to do a quick reminder. If someone wants to hop on the line and ask their question to either Jackie or our presenters from OPIP earlier, they are more than welcome to. You just need to raise your hand on the GoToWebinar control panel, and that will allow me to introduce you, unmute your line, and you can ask your question. In the meantime, we did get a few other questions that we can pose to our presenters, so I think I'm going to send them over to RJ and David first, and then we'll see if Jackie has anything to add. So one of the questions was, document and following up on self-management goals is a challenge. How do you build setting goals and follow-up into your workflows?
Well, I think every clinic has approached that a little bit differently. I'm going to go back to the children's clinic again. We started specifically with ADHD in terms of our who we were going to work on a shared care plan with. And what made it simple in that particular setting is that we're talking to those families every month as they're requesting their medication refills. So our nurses had a template for a phone note in terms of what they were supposed to document in terms of how the medication's working, how what side effects they're having, how's school going, and so forth. And so they were able to add in a few extra questions, and then also to have the drop downs that looked at specifically at goals and successes. And so we're actually talking to them once a month anyway. And so we incorporated those goal setting and talking about their successes into those monthly contacts that we were already having. With our asthma patients, we've been working as well on contacting them at least once a year, if not more frequently. And so we're doing a similar thing with that. So we're trying to look at when we're already having contacts with the patient and making sure that the decision support is there for the providers and for the nursing staff to do those extra steps while they're already having the contact with the families. We have a registry that we use for asthma anyway, and so we have exclusion lists so we know who we haven't talked to for their asthma patients. So we outreach to them if they aren't contacting us anyway. So medication refills tends to be one of the times, and that's true for many of the chronic diseases, but medication refills is one of the times that we have incorporated some of that goal setting into our workflow. That seemed a pretty simple and straightforward way to build it into what we're already doing. Do you have anything you want to add?
The only thing I'd add is just from a process perspective that's how practices are approaching it. They're finding places in their current existing processes where they can add an extra step potentially, but that's piloting and using small tests of change and doing PDSA cycles is the way practices are trying to solve this problem.
But a lot of them, I mean, that's partially why most of ours didn't have care coordinators and then have evolved to hiring care coordinators, because that's one thing that the care coordinator can do is do the loop back, follow phone call if they didn't have with their patients that don't have medicine. So I know like Chaos, for example, that they have kind of a monthly check-in with their patients.
Okay, thanks. I'm going to toss the same question over to Jackie. Is there anything you have to add about following up on goals and implementing that in the workflow?
I think with us it's somewhat similar. We have our nurse case managers who are actively working with these patients are doing calls to them at least once a month or sometimes more often, and they're helping manage the goals with the patient and update the goals. And then we also have a panel coordinators who are proactively outreaching to our patients who don't have scheduled appointments and are behind for things. So as they're going through and identifying that they're overdue for a preventive service or a labs for a chronic illness, they're going to look at the care plan and identify when was the last time it was updated and if someone needs to contact the patient.
Okay, and then there's been a few questions kind of along the same lines, Jackie, that I'm going to toss over to you. So one was about what EMR Legacy uses, and we know that's Epic. But there were some questions about whether these care plans can be accessed outside of the Legacy system, whether you're able to share with other healthcare systems. One question asked about, being a PCP in the community, it would be great to know that a patient has a care plan at the ED or Legacy. And so can you speak to that a little bit?
Absolutely. My understanding is that our care coordination note can be seen through Care Everywhere. So if you have that and you extract the patient's records, you should be able to see the care plan. The EDs are actively working if the provider is identified in our system as the primary care physician, that they contact that primary care physician when they're creating a care plan for the patient. But the challenge there is that some of our patients, especially the highest utilizers, are not going to say who their PCP actually is when they come to the clinic, report to the ED. So they're also trying to document that in the care team, and then in addition in the additionally into the ED care plan. So if they notice that it was Dr. Jones when the patient checked in, but the patient claims it's now Dr. Smith, they're going to document that Dr. Jones was the previous PCP and then contact both providers to make sure that they're working with the appropriate physician who is actually caring for this patient. And then we're happy to share what we've been able to create so far. Epic is not given us the best place to put this, so we're using the care coordination note for now in hopes that with some of the developments they're working on, that there's an actual care plan section that'll be just as fluid as this is, but a little easier to document in the future.
Okay, great. I'm sorting through some of the other questions here, and we will definitely, so those of you on the line who've asked about connecting you with Jackie or what she can share, we will follow up with her, and then any of you who have asked questions about that, we will go ahead and connect with you later. And then, give me just 1 second here. If there are any final questions, we can go ahead and take those. All right, so we do have one question about, to meet all the requirements for reimbursements, could an insurance company, especially a CCO insurance company, put together a shared care plan that would also count for PCPCH use? And I'm going to send that over to Evan.
Yeah, so again, how you all put this idea into action is essentially up to you. Certainly an insurance company or CCO could develop a care plan. I think that the potential difficulty in that would be whether or not the involvement of frontline staff who actually would be using the care plan, who would actually be making it a living document, a patient-centered document, whether or not they would be involved enough to make it actually work. So, covering the check boxes and making sure that the requirements are met is one thing. Again, implementing something that is functional and valuable for patient care and for the patient is something different. It depends on how you work with folks in your community and what sort of coordination. Again, there's some value, for example, within Jackie's system, legacy system, of where you've got patients crossing between the ER, specialty, primary care, et cetera, and everybody can see that care plan. That's very valuable. How a community structure is set up to support that depends on that community. Hopefully that offers some clarification there. And there's essentially, there's another question about Medicaid reimbursements and whether or not the covering costs of the implementation of these changes. And what I would just say is I really found Jackie's, David's, and RJ's information really valuable in terms of really making something that is patient-centered, involving the frontline staff in the development, making small changes, testing them, seeing if they're going to work before you make large changes, utilizing the staff that you have potentially differently, utilizing those really valuable, potentially very valuable touches. Every time we touch a patient or interact with a patient, that's a potential valuable interaction where we could offer some education or, again, touch on self-management guidelines that are established in a care plan and really make it a valuable experience for the patient. An important thing for us to do as well if we're utilizing workflows that we essentially already have, but we're enhancing those to provide better patient care. That's really what I would say in general. If you're doing those things, there's no question this provides value to the clinicians, it provides value to the patient. and the amount of money that's coming in for doing this depends on your patients and that sort of thing. Clinics that have a lot of these folks are getting significant reimbursement. Folks that have small numbers are not getting as much. The other piece that I'd finally say is that again, this care plan, I wouldn't, it's a requirement for the payments for the Affordable Care Act qualified patients. But again, there's more value to this than just the payment program. It is really valuable, again, as was laid out in this talk, to patients with a variety of issues, and maybe all patients with any chronic condition. All right. So we'll just wrap up here. I think we answered most questions. If there are things that we missed, we'll try and answer those questions, get back to you all, or connect you up with, again, folks that you've asked for connections with. Please, when you do get the survey after this presentation, please fill it out so that we know how we're doing. If we're doing a good job, if there are things we can improve, we'll depend on your feedback to be able to guide that. Again, the webinar materials will be, this recorded webinar and the other materials will be on our website, the PCPCI.org website. And any additional questions, you can email there at info@pcpci.org. And with that, thank you very much.